I am your host, U.S. Army flight surgeon and Iraq combat veteran medic, retired Colonel Dr. Damon Arnold. I have two people who are on today that are extraordinary. They do things for veterans every day. They probably wake up thinking about veterans, go to sleep thinking about veterans, and during the day they're with the veterans. So, really extraordinary people. It's our partner, Adelena Marshall. She's a VA mental health RN. I've gone on walks with her. She's walked me into the dirt. I mean, she can walk from place to place. Uh, I'm not going to even talk about how far she took me the last time we took a walk. And then we had our guest panelist, Carolina Stewart, an RN, a Master's of Science in Nursing, and a licensed clinical nurse leader. Our discussion today is going to be about the current VA nurses' work, conditions, and what needs to improve the next presidential administration. In our work, the nurses at VA, if you haven't been there, they work hard. I mean, hard to make sure that our veterans are taken care of. They are like surrogate family. And many of them, some of them are veterans themselves, but they have a heart for veterans, period. So I just have to applaud you on your services and thank you for your service to our veterans. So I'm going to start this out. And Lena, do you want to go first and just talk about the topic? This is a topic I think that's hitting a lot of fields. The public health workforce is being diminished, nurses in every discipline, but especially in the VA system. We've been talking about this for some time, the need to have more staffing and make sure we have enough coverage to take care of our veterans.
So, as many of you may know, that the VA right now has a budget crunch, and we are unable to hire the amount of staff needed to support the programs that the VA, the great programs that the VA has for our veterans. We're hoping that in the next administration that our veterans and the VA will come first, that they will realize that all the wonderful programs that they have, that it has to be supported with enough staff to deliver the care that our veterans so dearly deserve. Right now, they're filling positions on as needed basis. And so that's for the entire hospitals. So they might need EMS and they will hire that department over possibly hiring our RNs. Of course, we need our EMS personnel. We need our social workers. We need everything that our veterans need to help support them on their road to recovery. We want our veterans to come to the VA to get their care, to be supported by the VA, and we encourage them to come in. We try to avoid any delays in their care. And it's important that if they're not going to keep their appointments, to cancel it so that we can get other veterans in that slot.
Yeah, Carolina, so what do you see as the problems, the work conditions that you're confronting every day? And what do how, maybe you could describe that before we go on to what needs to be improved. But what is it that nurses are confronted with on a daily basis?
Hi, thank you for having me again.
Sure.
One of the main problems that I see, and I have to speak from both the bedside as well as the community care aspect. I was a bedside nurse for about 10 years until about 2 years ago when I transitioned over into community care, and even still being able to communicate and speak with the nurses at the bedside. A lot of the same issues still revolve around not utilizing our staffing we do have appropriately by ways of putting additional task loads and things on the nurses, steadily piling onto the things that they are required to do and not necessarily giving them the resources that they need to be able to do it efficiently. one of the main things we've been battling for years is a nurse to patient ratio, which California currently is the only state that does have a mandatory nurse to patient ratio. That is different specific to each unit, but it identifies the needs or the what we call the acuity level of care of our veterans to really determine the most appropriate nurse to be able to deal with those needs and not kind of overload them or allow for any room where there is oversight of, certain things. So staffing is always a main one, and being able to have those resources available for us to be able to function properly.
Yeah. So what is the ratio normally like? How is that sort of play out? I know you said it's different for different units. Yeah.
Yeah. Well, for California, it can be as small as, say, for instance, in their operating room, they may have one nurse to one patient, and that's their ratio. Or it might be a little bit more in their medical surgical unit, which might be one nurse every five patient. Right now in our hospitals, we're seeing more so anywhere between one nurse to between five, maybe six, and on extreme levels, seven patients. And that is more of an extreme nature, but it does occur at times. And more frequently than not, are we at the higher end of that ratio?
Yeah, because sometimes those patients need a lot of services. I mean, it's not like you're taking care of someone, sitting at home.
Yeah.
You're giving them medical care, medications, and making sure that the vital signs and all those things are, intact. And that's a lot of pressure.
And most importantly, outside of caring for our veterans at the bedside, we're working to with them to get them home. And in me being in my role in community care now, while they're in the hospital, we're communicating with the other nurses, the other interdisciplinary team, to really see what is it that they need to be able to best meet their recovery needs. And in doing that in the hospital, it's more than just passing out the medication and going to the next. We want to talk to our veterans about what they're taking, why they're taking it, how
Mhm.
can we, best maintain our health once we leave the hospital, and that takes time. So I think that's a big portion of that nurse patient ratio is really factoring in the time that our nurses need to be able to really educate and spend that time with the veterans.
That's really critical because if you don't know how to take your medications, I remember I was in an emergency room one time, and this one patient came back in, and she had been there for an earlier shift, and the person was really feeling sick, and she was vomiting and all those kinds of things, and they said, well, you're sick, but what have you been doing? What have you? And she, ended up getting suppositories. These were vaginal suppositories for a yeast infection, but she was swallowing them
Oh my.
because she didn't have somehow the communication didn't go through, correctly. So she was actually swallowing these things, and that caused, a miscommunication and education or breakdown that didn't occur before she left. And
Absolutely.
so that was really a terrible thing. So what do you think needs to be improved? How can we improve the process in the next presidential administration? What would you ask for? What do you think the needs are as a functional unit of nurses working?
So the nurses also are impacted by not having auxiliary staff that we need to. So if we don't have health techs, that's another task the nurses have to take on. And as Carolina stated, we have had four nurses with a caseload of 24 patients. Our mental health units need more support, more nurses, and that also causes an endangerment to the staff and to the nurses if we don't have enough. I think this new administration should look closely at the budget
Mhm,
and understand that our patients are coming in with more comorbidity, and that will take more time for us, just like the patient you just spoke of. That's unconscionable that they would think that and didn't have the right amount of education.
mhm,
Carolina's really involved in extending education to our patients and having the timeliness to be able to do it to where they understand. I also offer that education in mental health. And mental health, if our patients are not taking their medication appropriately, then we have reiteration and they're back in the hospital, many of them quite frequently back and needing mental health care. So we need funding. We need appropriate funding. Right now, the VA is under budget, and some of that could be related to the needs of supply demands and from COVID and having to increase staffing during that period. But many of our nurses is projected that in 2025, 2026, about 70% of them may be leaving. And we have to be able
Yeah.
to recruit and to retain. But Carolina can, expand on that.
Well, yes, definitely speaking to nurse retention, we have to focus on the things that, again, the nurses need to feel supported in our abilities to care for the veterans. With our ancillary staff, they function alongside us. They're the ones who assist with the vitals that may be needed in, extreme situations or just on a daily basis. And for this administration, we really do hope that they have the chance to look into, again, the nurse patient ratios, because while we are in a freeze right now where we're not really able to bring in more help, or we're pulling from other areas to support, but then taking away from other departments, we really need to be able to look at, again, is this a safe condition for the nurse to be able to safely administer care? So I agree with the need for ancillary staff, and just in general, we have to focus on ways to retain our nurses. We have looked into things such as alternate work schedules, which have seemed to be a benefit in helping the nurses' overall well-being, reduce burnout and fatigue. But we can't just stop there. We have to continue to appreciate the nurses and the staff overall who are taking the time, to be able to really dig into our veterans and ensuring that they're receiving proper care, and not just, as I like to call it, drive-by care, where you get the medicine and you just go. Like, we don't want that type of treatment.
Yeah, because that was one of the things, I was mentioning in an earlier show. For example, the public health workforce decreased by 50% during COVID, 50%. So there's a dire need for people in the public health arena, and that includes public health nurses and that kind of thing on the external world. But there is also, projections that you're going to have 20 to 30% of physicians in the next 3 to 4 years retiring. You have about 40% of nurses in the next 3 to 5 years who are going to leave the workforce. And that's going to put a great strain on, the needs that are in the workforce. You also have something that I was going to sort of bring your attention to and ask you about this, is that, when we have wars, almost every 10 years in a cycle in throughout the history of our country. And you have a younger population out there, OEF, OIF, and then you have an older population, World War II, veterans, and then Vietnam. And as the patients are getting older, it seems like you would have to have more coverage because you have people who are losing their hearing, their vision, maybe have more cardiac involvement, those kinds of things, where you have to have more of an acute care attention paid to them. So have you seen that, like, over time, as the population is getting older, that it's putting even more strain on the nurses who are taking care of them?
Yes, that's one of our concerns, and we're expressing that they take more care, they take more time, and at this time, with the way the budget is, they don't even want to approve overtime. I've been in the hospital in private sector, and at 4 o'clock, those nurses are gone. Our nurses will still stay, even though we have to tell them they're supposed to get paid. But that's the dedication that we have to our veterans, that we will stay and we will care for them until somebody can come and relieve us. But the burden of caring for our veterans becomes greater, because many times they don't even come in until they're very, very sick. And then after, once they are admitted, with all the comorbidities and many problems, high blood pressure,
Mhm.
stroke symptoms, um, diabetes. All that takes time to work with the patient. We can't just rush through and hang an IV. And right now, there's a shortage on IV fluid. So the
Mhm.
nurses have to mix those meds. They're not having pharmacy do it. The antibiotics are mixed now by the nurses,
Huh?
because many medications are administered through IV fluids.
Mhm.
And because of that shortage, we have to find a way to cut back on the usage.
Wow, that's amazing. And so it's more than just an issue also of having enough staffing, but it's I think Carolina was really pointing it out. Having extra duties thrown on you as well, on top of the responsibilities you as your part of your core mission, as a nurse. And so, what are the things, we were talking about staffing, but it sounds like you also needed the equipment, those things that you need to do your job. And that seems like that's a need as well. Do you see there's a shortage in having the things you need to actually perform?
I think the VA, this VA at Jesse Brown, has been very proactive in
Mm-hmm.
providing equipment and wheelchairs. But
Hmm.
along with that, there are some patients have to be escorted to X-ray, MIRs, and that might take two nurses, because that patient may be at risk of coding. So that's two nurses gone from the unit. And sometimes we don't have enough transporters. So to get the patient down timely, the nurses have to take them down, because we don't have the health techs either, nor the transporters. So there's a bigger picture to healthcare than patients just coming into the hospital, um, recovering and go home. There's a lot that goes into achieving that recovery and being able to send that patient home. And like Carolina said, after their discharge planning, that takes a lot. Who's going to care for them in their environment that they're going to? Does the family need education on that? Who's going to set up the physical therapy and respiratory therapy, whatever they need? I mean, we need more nurses to decide that plan of care, and that's what Carolina and them are tasked with.
Yeah, yeah. Because I was thinking also that, I know a lot of jobs that if you don't have enough people, and part of your staff, then you have to start making, and you were mentioning it in part about, the overtime and that kind of thing, and people are staying. But, also for your own downtime, for your own mental health, because you're a caregiver. We always talk about caregivers at home, but you are a caregiver. So you're caring for multiple people. So how does that play into things about taking your vacation time, making sure you get your breaks, and just a little bit of downtime, because it can be very, very stressful in those situations.
Well, our nursing staff has scheduled breaks, and oftentimes they can't take it. So far, I'm not aware of any interruption in them taking their vacation time, but
Okay.
it's hard for them to take vacation time that is unplanned. So they may
Right.
plan to go somewhere trying to capture or reduce costs for their flights and hotels, and then they're waiting to get that approved, and it may or may not be approved.
Mhm.
So those are other things that causes nursing dissatisfaction. They want to spend time with their families and stuff too, but we're always putting our veterans above anything that we're doing or planning. We're, like you say, we think about them all the time. You
Mhm.
can't even drive home without thinking, I hope
Yeah.
Mr. So and so and Mrs. So and so is okay. I hope they got this on time. Things like that. And
Mm.
working at a VA and working with our veterans take a special kind of person to work here because we're not here for the financial
Mhm.
aspect. We're here for our veterans.
Yeah, yeah, and that's just really admirable. I mean, and people have to realize that, as veterans, as people who are receiving these services, and I've always had a incredible relationship with my nurses when I go to the VA. They always sit me down and say, you need to get your vaccination. Shut up and sit down. So I comply. I just put my hands up. So, what do you think veterans can do on this side, because we're, the ones receiving care, and in part, the veterans can suffer from the lack of care, right?
Right.
If people are so tied up they can't, be taken care of. What do veterans need to be saying or doing? Is there anything we can do?
They need to hold their legislators accountable for the promises that they made to them during election seasons.
Hmm.
So it doesn't have to be a national election; it could be local elections. But they need to hold them accountable. Call your legislators, ask them questions, ask them why is the VA that you've chosen to go to don't have the adequate staff to provide the care that was promised to them. So the employees of the VA can't be the only one that is having a voice about what's going on. We need our veterans to participate in their care and demand the care that was promised to them when they went off to serve to protect our country and to protect us.
Hmm. And Carolina, do you have any thoughts on that too?
And yes, and I think again, working in the community care aspect of it and knowing that we do have more elderly veterans, as you mentioned, um, from different war settings that we're caring for now,
Hmm.
once they get home, they have to be receptive to the support and the care that they're receiving from their families, as well as some of the resources and the programs that the VA have. A lot of times when I'm speaking with my veterans who are planning for discharge home or have already been discharged, and we are talking about physical therapy or maybe home nurse visits, even for well-being checks, there is such a pride, of course, and an autonomy that veterans hold to themselves. And I just want to remind them that we're here to help. You have support, even family members that oftentimes want to help, and you don't, the veterans might not want to feel that they're putting that burden. Allow us to help you. Listen to the programs and the resources that we do have and how it can best benefit you, and utilize the resources because they are there, and it can help to take some of that strain off of especially the healthcare management at home, and to prevent them from frequent hospitalizations or readmissions. Really listen to the support that's around you and be willing to kind of utilize the resources that are available, so that
Oh.
we can show them that the funds that are being put into this program, they are being used and they are necessary.
So how can people contact the program?
So they can always start by speaking with their primary care provider. The veteran does need to be assigned a primary care physician in a VA, but once they have established that, they can just speak to them about certain needs that they feel that they have. And a lot of time, the primary care physician will navigate them or direct them to the appropriate department, whether that's myself in community care, or one of my colleagues, or whether that is, I know we spoke, you all had one of our colleagues in community care, Janika Walker, in today with caregiver support
Mm.
program. So
Yes.
yeah, we communicate. We are an interdisciplinary team. So start by talking to your primary care physician, or even if you just call in, and I'm sure even the operator can help direct you to the right department. But just speak your needs, your concerns. But I believe the primary care physician would be a good point of contact.
Well, I know two nurses that are going to be having a special place in heaven. Adelena Marshall and Carolina Stewart. Both of you are, remarkable. I just, feel like this is the kind of human being we need to have in the profession.